Good morning, everybody. I would like to thank the organizing committee for the invitation. I am Myrna Serapião, corneal and external eye disease specialist. Today's topic is iatrogenic dry eye. And dry eye has been a high prevalence in the world population and can be caused by several iatrogenic interventions, such as the use of medications, both topical and systemic, use of contact lenses, surgeries, and other procedures, and we must remember that these symptoms can compromise the quality of life of the patient. DUES 2, which is the Dry Eyes Workshop, published in 2017, covers various aspects of the disease, and it introduces a new chapter, that is iatrogenic dry eye. Now, we know about the importance of the dry eye in conditions such as cataract surgery and refractive surgery, which can impact results during the post-operative period. And if we consider the epidemiology of dry eye, we know that the general prevalence can be extremely high, and depending on what is studied, if symptoms and signs, which is nowadays recommended by DUES. We know that the disease affects older patients, and with greater age, there is the question of aging being closely linked as a factor of risk for dry eye development. But we also have the question of computer users, and then how to bring it to a younger age group. So nowadays, and looking at different age groups, dry eye is a disease extremely prevalent. Considering again the risk factors, we have computer usage, the use of contact lenses, and the issue of the medications and surgeries. And so all of this can collaborate to trigger signs and symptoms of dry eye in these patients. Considering the pathophysiology of the disease, we have here several aspects, just highlighting the use of systemic drugs. Up here with the arrow above, the question of using refractive surgery or contact lens, both leading to reduced production from the tear film. And here below to the right, we can also see the contact lens interfering with the stability of this tear film. And this may lead to increased evaporation of the tear and evaporative dry eye. Iatrogenic dry eye can be classified into different types. Firstly, we have the drug-induced iatrogenic dry eye, which can be due to systemic or topical medications, and we have contact lens induced, especially important on account of the number of young people and patients who wear contact lenses, or surgery-induced dry eye, such as refractive surgery, corneal transplantation, cataract surgery, eyelid surgeries, and also other surgeries such as glaucoma, vitreoretinal surgeries. All of them can induce dry eye in patients, and some other procedures such as botulinum or cross-linking. To remember, also other diseases can significantly impact, such as GVHD or graft versus host disease, and we will speak specifically about one of these. And so, iatrogenic dry eye induced by systemic drugs, we have some that we need to highlight as they are more important in triggering dry eye in these patients, such as antidepressant drugs, antihypertensives, antihistamines. We know that they reduced the tear film production, and hormone replacement therapy in menopausal women, we know it's related, and for a long time it was thought that it was the menopause that led to the dry eye, but more significantly, hormone replacement therapy can induce dry eye in these patients, and the use of anti-androgenic drugs in the treatment of hyperplasia in benign prostate can also induce significant dry eye in this group. And we also have several other systemic drugs that can cause dry eye, but those highlighted previously are the most significant. In terms of topical drug-induced iatrogenic dry eye, we also have a plethora of drugs that can lead to dry eye, highlighting here the importance of preservatives, especially benzalkonium chloride, and we know the potential for toxicity to the surface epithelium and the pattern of destabilization of the tear film, and also highlighted, due to the high prevalence of the disease, of long-term use and the possibility of association of these topical drugs, i.e. the use of anti-glaucoma drugs that are often used throughout the life in an associated way, and we need to associate drugs for us to get the target IOP. Remember that many of them use benzalkonium chloride as the preservative. We saw the aggressive potential of benzalkonium chloride, which on one hand increases the absorption of the drug, but on the other hand, it can be toxic to the surface, highlighting also the analogues of prostaglandins due to the effect on dysfunction of the Meibomian gland. And analogues are extremely damaging to the glands and can often lead to dysfunction, which will eventually lead to evaporative dry eye. So, like I said, about 60% of patients treated with anti-glaucoma medications have reported symptoms related to dry eye. And this is a population that we should pay special attention to. And, as I said, also remember the preservatives, especially benzalkonium chloride in dry eye induced by topical drugs. It has a toxic and pro-inflammatory effect and also a detergent effect. Remember that prolonged exposure to benzalkonium can lead to the destruction of the mucin layer, then leading to quite significant dry eye. We always prefer less toxic preservatives like purite, perborate, polyquol, and sophsia. Now, we remember that patients who use the glaucoma drugs are often required to use a combination of 1, 2, or 3 drugs, and this increases the potential for inducing dry eye in these patients. And whenever possible then, we give preference to topical drugs without preservatives in order to reduce the incidence of iatrogenic dry eye, which is especially in this group of glaucoma sufferers. Another area of great importance is that of iatrogenic dry eye induced by contact lenses. There was also a workshop related to the discomfort which is related to the contact lens use, and we can observe the two major groups of etiology are those related to the contact lens on the left and on the right related to environment. And here we will specifically talk about the impact of the contact lenses on the lipid layer and on the stability of the tear film and the issue of blinking. All of this can be related to the use of contact lenses. Regarding the epidemiology of contact lens-induced dry eye, we have some big studies. For example, the Canadian study that showed that dry eye was present in 50.1% of users of contact lenses compared to the 21.7% of non-wearers. The Beaver Dam study, a very long study, too, showed that lens wearing is a risk factor for triggering dry eye. And this Chinese study, with 1,885 students, showing that dry eye was present overall in 8.4%. But if we specifically looked at the contact lens wearers group, then dry eye was diagnosed in 32.8% of the patients. A discussion that DEWS brings is, today we have specifically for the diagnosis of dry eye symptoms and objective signs. Many studies indicate the incidence of dry eye related to contact lenses taking into account only symptoms. And so, it is important in the evaluation when we approach these patients to use objective tests so that we have a real measure of the prevalence of dry eye in the lens-wearing patients. Then there is the classification of the iatrogenic dry eye related to contact lenses into two groups. And the first is contact lens-induced dry eye in those patients who had no signs or symptoms prior to using a Clyde contact lens. And then, after some period of use, they started to have symptoms and obvious signs of dry eye on examination. And there's that second group, which is the dry eye associated with the use of contact lenses that are patients who already had dry eye symptoms or signs prior to the use of the Clyde contact lenses. And obviously we will talk more about lens-induced dry eye. But what then would be the mechanisms associated with dry eye induced by the contact lenses? Reduction of the lipid layer of the tear film, that will cause instability of the tear layer with reduced breakup time and also leading to a change in the mucin layer, alteration of the structure and physiology of the Meibomian glands, and finally an increase in evaporation and increased osmolarity. The patient may progress to evaporative dry eye and, in more severe cases, mixed dry eye, also evolving with decreased hair film production. And so several ocular surface changes induced by the use of contact lenses can be explained by contact lens-induced dry eye. And so we watch an increase in the density of Langerhans cells in the cornea after 1 week wearing lenses, a decrease in goblet cell density in contact lens wearers, patients significantly compromising the mucin production, which leads to a change in the cornea contact lens interface or lid wiper epitheliopathy, which is frequent in the patient wearing a contact lens. And it is that pattern of staining of the eyelid margin which currently is even a part of the diagnosis for dry eye. And also remember that changes in the secretion of the Meibomian glands, which may be related and altered, mainly in more chronic sufferers.
E alteradas no usuário, principalmente no usuário mais crônico de lentes de contato.
And we can't also forget about the environmental factors that can exacerbate contact lens-induced dry eye, such as long-term users of computers in those patients who also use contact lenses with quite a significant effect on starting symptoms. Now, another area would be dry eye induced by surgeries or procedures. And we know that surgeries of the anterior segment can exacerbate or induce dry eye or ocular surface disease dry eye, which can lead to decreased vision and the emergence or worsening of the symptoms, and obviously an unhappy post-operative period. Dry eye and cataracts, specifically talking about cataract surgery, are conditions that are associated with aging. Most cataract surgeries are done in older patients, and there is also the question that most of these patients going to surgery for cataract are asymptomatic from the dry eye point of view. And if we do not make an assertive diagnosis, we can lead to aggravation or onset of symptoms in the post-operative period. And remember that cataract surgery can reduce or exacerbate dry eye for an average duration of 3 months, with a return to normality in the vast majority of these patients. What are the effects observed on the film tear? On average, after 3 months, we see an improvement in the pattern of the film tear in the post-operative period, that being up to 6 months. And we observe a reduction of the BUT, or the tear breakup time, reduction of the lacrimal meniscus. And you can observe an increase in the color pattern of the surface, reduction of the tear volume, and also the myoglobin glands can be changed. And what are the mechanisms then associated with the cataract surgery-related disease? Inflammatory mediator release, which is common to the surgical process, leading then to changes in innervation and a decrease in the reflex stimulus of tear production, leading to tear film instability, toxicity of preserved eye drops used post-operatively. We know that the larger the incisions, the longer the recovery time of the corneal innervation, leading also to decreased reflex stimulus for tear production. Complicated surgeries with longer surgical time increase the exposure to light from the microscope, inducing surface damage, and the dysfunction of meibomian glands in longer surgeries have also been observed in post-operative cataract patients. There are studies showing the incidence and prevalence of dry eye in these patients and in the pre-operative period for cataracts. Now, diagnosis of dry eye patients pre-operatively with aggressive treatment has been shown to produce fewer symptoms post-operatively. This study shows that if we look at the association of osmolarity with metalloproteinase, with a very high prevalence in pre-operative period of cataract surgery, conventional or femtosecond laser-assisted cataract surgery seems to make a difference. And we know that the femtosecond laser, due to the design of the incision and docking in the limbus region, can injure goblet cells and also seems to induce dry eye more significantly when compared to conventional techniques. And so remember, a patient who has, for example, Jorgen syndrome tries to avoid laser eye surgery or reduce the incision size or even aggressively treat the patient preoperatively to avoid symptoms and unsatisfactory visual results post-operation. There are studies comparing conventional techniques with the femtosecond laser-assisted technique, showing that the laser technique can induce a longer period of dry eye when compared to a conventional technique. The classic example of surgery that induces this dry eye is refractive surgery, and we know that the vast majority in the preoperative period can present with a meibomian dysfunction, which is highly prevalent in younger patients, and not post-operative, the dry eye that we note has a neurotrophic component because of the serving of the nerves or nerve changes related to LASIK are much more than with PRK and LASIK-2 at a higher prevalence than SMILE. Now remember that it will be transient, and after 1 to 6 months the patients tend to recover. But in those cases where the patient already had dry eye and it had not been previously diagnosed, it may take longer time, and there is a higher incidence of chronic eye in these patients. A more assertive diagnosis pre-operatively is therefore important. It is to avoid a more chronic problem in the post-operative period, which can detract from the surgical outcome in these patients. And there is another study showing that after PRK and LASIK, it is not that frequent, and that it is more frequent when there is an association with previously undiagnosed dry eye. Now to corneal stud surgeries also, and obviously here the classic example is corneal transplantation, which can induce iatrogenic dry eye. And we know that corneal transplantation through a 360 section, remembering here that it is a penetrating transplant, can lead to a change of tear film production, which tends to recover after 6 months to 1 year. Remember that treatment of pre-existing blepharitis dry eye can improve and avoid complications in the epithelium. Epithelial abnormalities such as epithelial defect, punctate epitheliopathy, and extreme filamentous keratitis related to dry eye may present 63, 75, and 14% in the post-operative period. In fact, intrastromal rings can induce a transient dry eye that lasts from a week to 15 days, and with a cross-linking, there is the risk of melting in allergies with no control and in severe dry eye preoperatively, and it also induces dry eye there with no major repercussions, obviously if this patient does not have a previous dry eye. Glaucoma surgeries, especially with the use of mitomycin C or 5-fluorouracil, because of the toxic nature of these substances, can also induce instability of the tear film. Remember that these patients may previously have been using concomitant topical anti-glaucoma drugs that increase the possibility of inducing the dry eye. Remember, as already discussed previously, the use of preservatives increases the penetration of the drug, but destabilizes the tear film and the ocular surface. Remember the association of glaucoma with old age, which is already a factor and an important risk for triggering the dry eye by decreased tear secretion, and also of the association with the analogues of prostaglandins, thus inducing dysfunction of the meibomian glands. Are patients, specifically those undergoing glaucoma surgery, are they patients who have a very large potential, a rather high prevalence of dry eye by this variability of factors that can attack the tear film and the ocular surface? Eyelid surgeries, especially blepharostomies, are also associated with dry eye, and this can lead to exposure with excessive evaporation. And if that patient has previously had LASIK or the previous hormone replacement, it is a factor of risk for triggering dry eye post-operatively. And remember lagophthalmos, with the sclera showing as a result of surgery, it too can induce more dry eye in these patients. Ptosis correction, if there are also marked exposures, this patient can evolve post-operatively with signs and symptoms of dry eyes, which should be treated. Now, procedures such as the use of botulinum toxin also cause possible complications, including dry eye. And what would be the mechanisms? Weakening of the orbicularis oris muscles, reduced eyelid tone, leading to a decrease in tear exchange, and the lubrication of the ocular surface and blink exchange. Now, these can induce excess tear film evaporation and delayed tear film exchange, and in some more serious cases, and rarer obviously, a direct toxin diffusion to the tear glands and meibum. Remember that all these things may be involved, and pay particular attention to this group of patients. Retinal diseases and dry eye, which occur in certain age groups, and also molecular degeneration and diabetes, which are conditions associated with aging. Type 2 diabetes often affects older patients, which also increases the risk of triggering or development of dry eye. There are studies showing that vitreoretinal surgeries can cause dry eye, leading to epithelial damage of the conjunctiva and cornea by the disruption of the local anatomy, goblet cell reduction, reduction of mucin production, alteration of tear film cytokines inducing dry eye, and that the patient may have significant symptoms post-operatively. Now sure, the vision aspect is more significant, but we mustn't forget about the quality of life of this patient. It is important to remember that the vast majority also may be older, which is a risk factor. And as I said previously, the concurrence with other dry eye related illnesses in these patients, such as diabetes. In this study, with 140 patients who underwent vitrectomy and brachytherapy, 63% had symptoms compared to a control group. And there was a reduction in the tear film breakup time, the reduction of goblet cells, but we did not observe a decrease in tear film volume.
Existia aí uma redução do tempo de ruptura do filme lacrimal e redução dessas células caliciformes, porém não foi observada ali uma diminuição do volume lacrimal.
Always remember that here, the vision is more important, but remember also the symptoms that these patients may present post-operatively. Intravitreal injections are also another important aspect that we have to consider, as there are multiple procedures that can alter the conjunctival anatomy. If the patient already has dry eye previously, that they may predispose them to changes in the local flora, including the risk of developing endophthalmitis, so pay attention to this group of patients who undergo surgeries or procedures such as intravitreal injection. And finally, some other conjunctival interventions, such as tattoos on the conjunctiva and conjunctival piercings or implants. It is not uncommon for us to see complications secondary to the patient undergoing these so-called aesthetic procedures. And we also have the possibility of problems because the eye damages the goblet cells and causes significant surface inflammation of the eye, which also induces tear instability, leading to iatrogenic dry eye in these conditions. And there are other less serious complications if we consider the potential and the risk of complication of these procedures. In conclusion, iatrogenic dry eye can be caused by topical systemic medications, contact lenses, and surgical and non-surgical procedures. And so it is very important to diagnose and manage early, as this avoids more severe symptoms and conditions in the future, in addition to unsatisfactory post-operative results, with visual results in contact lens wearers and compromising the quality of life for these patients in the future. Thank you very much for your attention.